Hello, this is Tom Lüscher talking to Brian Halliday at the Royal Brompton Hospital, and today we would like to discuss specifically a recent paper presented at the European Society of Cardiology this year by Stefan Anker and Milton Packer, the Emperor Preserved trial on empagliflozin in heart failure with a preserved ejection fraction. Welcome, Brian.
Thanks very much.
So we all learned that the sodium glucose transport inhibitors are highly effective in heart failure, but so far it was mainly in patients with heart failure with reduced ejection fraction that these drugs were tested directly. Now, this new trial tries to do this in preserved ejection fraction, which in their specific case meant that the ejection fraction would be higher than 40%. So according to the new ASC guidelines, this is both HFmrEF, the tongue breaker that now is renamed as ejection fraction, heart failure with mildly reduced ejection fraction, and true HFpEF above 50%. So let's, Brian, why don't you look at the patient population? These are around close to 6,000 patients randomized to empagliflozin and placebo. What can we say about the patient population?
Yeah, so a really huge patient population, a real feat to be able to recruit almost 6,000 patients. So as we can see, they're an old population, so an average age of 72. As we expect with patients with heart failure with preserved ejection fraction, around a half for women. Perhaps we would have expected even more than a half of women based on some of the epidemiology we know with heart failure with preserved ejection fraction being most common in women. Perhaps that's also driven slightly by the fact that there is also the mildly reduced ejection fraction patients, which is perhaps more akin to the reduced ejection fraction group. The majority of patients, so 3/4 were white, just a small number of black patients, under 5%. So again, perhaps some difficulties in extrapolating the evidence to other populations apart from white Caucasian patients. And there was most patients were recruited in Europe, so almost 50% of patients. Latin America got almost a quarter of patients, so impressive recruitment from Latin America too. About 1 in 8 patients recruited from North America. And fairly typical MOHA class, so the vast majority of patients were in class 2 and a small number in class 3 at around 20%.
Yes, and very few with very severe heart failure, which is also interesting. Yeah. Okay, let's look at the main results that are shown here. What can we say here, Brian?
So overall, there's a 21% reduction in the primary endpoint. So the primary endpoint, as with other SGLT2 inhibitor trials like DAPA-HF and Emperor Reduced, was a composite of cardiovascular death and hospitalization for heart failure or an urgent visit for heart failure requiring diuretics. So there's a 21% risk reduction, and this was highly statistically significant, and the curve seemed to separate very early on, so there seems to be an early effect, which is pretty impressive. If we dig a little bit further down into the composites of the primary endpoint, we see that this was driven by a reduction in hospitalizations for heart failure, and indeed there wasn't a reduction in cardiovascular death that perhaps we saw with DAPA-HF in the reduced ejection fraction group. So in this group of patients with preserved ejection fraction, the primary endpoint reduction is driven by heart failure hospitalizations.
And how does it compare to patients with HFrEF in terms of number of hospitalizations?
So overall, the event rate it seems to be about 10% at 12 months in the placebo arm, and in DAPA-HF the event rate was slightly higher than that. It was 15%. So the number of events seems to be slightly less in this population, and perhaps that's not completely unexpected, given what we know about the populations with a reduced ejection fraction who primarily have a primary cardiac disease, and then this group of patients which are more of a heterogeneous group who have hospitalizations for a number of other reasons as well as heart failure.
What's impressive, as you mentioned, is this early divergence of the curves, and that also was seen with the other trials with sodium glucose transport inhibitors, wasn't it?
Yeah, absolutely. So I think we're still unraveling exactly how these agents have their effects in people with heart failure, and there's lots of potential mechanisms driven from preclinical research. We know that they have a slight diuretic effect, and is the magnitude of the effect we see here early on too much for it just to simply be a diuretic effect? And how else could it produce such a rapid effect other than diuresis? And these are all interesting questions that perhaps we don't have perfect answers for yet.
Yeah, we don't have good comparisons with what a diuretic would do instead, huh?
No, absolutely.
Because these trials are not done because they're all generic and nobody wants to fund it, I guess. Yes. All right, so let's move to the subgroup analysis that we have here. Overall effect we said, and diabetes, or with or without diabetes, that's a common picture with the sodium glucose transport inhibitors in heart failure. Huh? It doesn't matter whether you have diabetes or not, isn't it?
Yeah. So it's it's consistent with the other evidence, and suggests we should be using these regardless of diabetic status.
Right. What about this ejection fraction picture? What can we say there?
So I think this is really intriguing, and I suppose it's when you look at this forest plot, you wonder whether the effect attenuates at higher ejection fractions. And indeed, from the presentation with the Emperor pooled analysis, so pooled analysis from both Emperor reduced and Emperor preserved, the effect in reducing heart failure hospitalization seems to be lost when your ejection fraction gets above 65%. So again, perhaps there's an attenuation of effect or even loss of effect at higher ejection fractions, and perhaps we need to be using a cutoff of 60 or 65% and focusing on those patients with an ejection fraction below that.
Yeah, I mean, coming back to the definitions of heart failure, according to the new 2021 ESC guidelines presented by Teresa McDonough and Marco Metra at the European Society of Cardiology this year, you would say that the first group below 50% is actually heart failure, as they call it now, with mildly reduced ejection fraction. So you have a most dominant effect. It's a bit less than in HFrEF, which makes sense because they're less sick, but that's what you could say. And then, of course, the next strata, over 50 to less than 60, just barely made it with a confidence interval of 0.64 to 0.99. While, as you mentioned, when you go above 60%, the effect is lost. And is this still a group of patients that needs specific treatment, do you think?
So I think, I suppose I have two questions when I think about the group with ejection fractions above 60 or 65%. And the first one is, do they truly have heart failure? So the inclusion criteria for this trial was an NT-proBNP above 300 if you're in sinus rhythm, or above 900 if you're in AF. So could you be a 75-year-old with breathlessness with an NT-proBNP of 350 and not truly have heart failure? And are some of these patients with low atrial fibrillation, with shortness of breath due to something else, and high NT-proBNPs driven by their atrial fibrillation? And then maybe the other question is, what's the cause of their heart failure, and do some of these have phenocopies of different things that maybe actually have specific treatments? Are some of them patients with non-sarcomeric hypertrophic cardiomyopathy who have hyperdynamic ejection fraction typically, and perhaps don't respond or respond in different ways to neurohormonal inhibition compared to patients with reduced ejection fraction?
Maybe some of them also have hypertensive heart disease, possibly, and yes. Then the other striking finding is that this mainly works in the elderly. Is this because they were more patients, obviously, but not hugely more? I mean, still in the younger group, below 70, it's more than 1,000 patients. So it's not a small group. How do you explain that?
I think it's, an intriguing hint that, there may be a particularly strong effect in elderly. I don't think we can read too much into it until we understand more about exactly how these agents work and why they may work more strongly in elderly patients. I think for the moment we should be giving this to any patient regardless of their age, and certainly not withholding it in elderly patients. And giving it to everyone.
And then, of course, we have this tendency that females have a greater effect. That's what we saw also in other trials, didn't we?
Yeah, so again, we've got lots to uncover about sex differences in heart failure. I think from the Entresto trials, we saw that Entresto may have effects at slightly higher ejection fractions in women, and perhaps that's because the true ejection fraction in women, or the normal ejection fraction as women, is slightly higher than in men. Again, there's lots for us to uncover, and it's a rich area for research in the future.
Yeah. So we can really say that these drugs, these sodium glucose transport inhibitors, are an amazing new armamentarium for us as treating heart failure with or without diabetes. And indeed, in the new ASC guidelines, they are at the same level now as the classical drugs we're using, like the ACE inhibitors or ARNIs, and beta blockers and mineralocorticoid antagonists. So we have really 4 pillars in heart failure to treat these patients, and this is truly an important progress in this field of cardiology. So thank you very much, Brian. It was a pleasure to talk to you, and I hope our audience also enjoyed this discussion.
Super.
Thank you. Bye. Bye-bye.